limited responsibility as well as
now it's done. Good morning. Today we'll be talking about primary angle closure glaucoma. Previously we spoke about open angle glaucoma, where all the structures of the anterior chamber angle are visible through the gonioscopy, whereas in angle closure glaucoma the angle structures are not visible, so it is that's why we call it closed angle. So how angle closure glaucoma happens? Because of this is because of the increased resistance to outflow because of the peripheral iris, which is covering the trabecular meshwork, and this prevents the aqueous humor from reaching the outflow channels. So if you see in this picture, the aqueous humor is formed by the ciliary processes in the posterior chamber, which through the pupil goes into the anterior chamber and drained at the angle by the trabecular meshwork. This is the normally how it happens. But in some anatomically predisposed patients, the lens and iris diaphragm, it is pushed a little forward, and because of which there is pupillary block which is happening at the because of the iris. This pupillary block, this causes collection of the aqueous humor in the posterior chamber. So the angle of the anterior chamber, which has trabecular meshwork, it is pushed against the iris. So because of this, the angle becomes occluded and there is no drainage of the aqueous humor. This is what happens in case of angle closure glaucoma. It may be primary in anatomically predisposed eyes. What are the risk factors for angle closure glaucoma? I'll be telling you, and it may be secondary because of the other causes. So historically, nomenclature of angle closure glaucoma has been confusing, and different people gave their different nomenclatures and different classifications. But what we are going to discuss today is the 21st century consensus classification, which is the most accepted classification. So sometimes angle closure glaucoma was described by adjectives like congestive and non-congestive, and compensated and non-compensated, because what they said previously, that all the angle closure glaucoma have congestion of the eye, that is it presents with the redness and ciliary spasm. But it is not true. There are some cases which do not present with redness of the eye and still they have angle closure glaucoma. Similarly, previously they used the term acute, subacute and chronic, which shows the time course and presence of symptoms. But these classifications are not used nowadays. So previously it was latent, subacute or intermittent, acute and chronic. These are the types of the glaucoma, angle closure glaucoma. So in the latent angle closure glaucoma, an open but narrow angle, and it closes under certain circumstances, especially when patient is doing a near work, or in the evening time when pupil is mid dilated. Those are the or patient has some emotional outburst, or some adrenergic surge, some exercise. Because of that, pupil dilates, and in mid dilated pupil, angle closure happens. This is the latent. In subacute or intermittent, there is a recurrent self-limiting episodes of angle closure with raised IOP, and symptoms may be mild or they may be absent. Most commonly, patient has mild eye pain or mild headache, and it subsides of its own. There is no need of any treatment in case of subacute or intermittent. It subsides of its own. Whereas in acute angle closure glaucoma, there is sudden elevation of IOP, and patient has very severe shooting pain and headache, and there is blurring of the vision. In case of chronic angle closure glaucoma, patients are asymptomatic, and they have elevated IOP or peripheral anterior synechia. What are the disadvantages? This classification, it does not give the full spectrum of the disease, and sometimes latent patients may also need treatment. So this is not accepted classification. The accepted one is the 21st century consensus classification, which divides angle closure glaucoma into different subtypes, and it relies on 3 parameters. The parameters are: the first is IUP measurement, that is there should be increase in the IUP. Second one is gonioscopy. When you do gonioscopic examination, the angle should be occluded, or it is an occludable angle. Next is, when you do disc evaluation, there must be some cupping or some features of the glaucoma which should be present. And once you do a functional investigation such as perimetry, it shows a corresponding visual field defect in the perimetry. So if all these factors are present, then we label patient having angle closure glaucoma and different types of angle closure glaucoma. I'll be telling you what are the different classification of angle closure glaucoma. In other words, patient's clinical examination alone determines the staging of the disease, regardless of presence and absence of symptoms, duration, or intermittency. In the previous classification, we had it was a very subjective classification, that the patient had to tell that I have pain and those symptoms. But in this classification, it is a very objective classification where the clinician examines and he decides the patient has glaucoma or no. So it divides glaucoma into 3 forms, that is primary angle closure, suspect. In suspect, there is more than 270 degree of iridotrabecular contact. What is iridotrabecular contact? Is nothing but once you do gonioscopy, you see that there is in 260 degree of the in 270 degree of the total, there is angles are occludable. Okay, and there is absence of any peripheral anterior synechiae. There are no synechiae. Patient has normal IOP, visual field, and optic disc. Okay, so there are no signs of glaucoma, but angles are occludable. So you do indentation gonioscopy to differentiate between the occludable angle and actually occluded angle. So so what is important, these patients have risk of angle closure glaucoma about 30% within 5 years. So you should advise patient accordingly. Next is the primary angle closure. What happens, there is more than 270 degree of peripheral iridotrabecular contact on gonioscopy, plus patient has either raised IOP or presence of peripheral anterior synechiae. Okay, so these are nothing but the peripheral anterior synechiae. These are the synechiae which is present at the periphery of the angle, and these synechiae is what causes the angle obstruction, and there will be normal disc and visual field examination. So in this, either patient has abnormality in the structure of the angle, that is peripheral anterior synechiae, or in the functional, that is there is elevated, the function of the angle is abnormal, that is there is elevated intraocular pressure. Third is primary angle closure glaucoma, that is there is more than 270 degree along of the iridotrabecular contact and elevated IOP. Along with this, patient has visual field changes on perimetry, and once you do optic disc evaluation, you see there is significant cupping and there is presence of now fiber layer defect. Okay, so the angle is in this type of glaucoma, angle is abnormal in both the structure and functions. So and patient has optic neuropathy. Okay, the other classification some people use are the pupillary block glaucoma, plateau iris, and lens induced glaucoma. Okay, so what is pupillary block glaucoma? There is a relative pupillary block in case of primary angle closure glaucoma, and many a times we put meiotic agents such as pilocarpine that induces glaucoma, that is meiotic induced angle closure glaucoma. And third is because of the posterior synechiae due to recurrent chronic uveitis in these patients. There will be posterior synechiae between crystalline lens, intraocular lens, or anterior hyoid face that will cause blockage of the pupil, and that will lead to pupillary block glaucoma. Second is plateau iris. In this, this has true plateau iris and pseudo plateau iris. Pseudoplateau iris is because of the iris and ciliary body cyst or any tumor of the ciliary body. True plateau iris, I'll be explaining you in a while. Third entity is lens-induced glaucoma. What happens because of the swelling of the lens? The angle structures are pushed anteriorly. Okay, iris and angle structures, they are pushed. Iris is pushed anteriorly because of the swelling of the lens, and this will block the angle and trabecular meshwork. That will lead to again glaucoma. That is lens-induced glaucoma, angle closure glaucoma. Okay, so it may occur because of the intumescent lens, such as phacomorphic. It is also called a LIG or lens-induced glaucoma. And there may be subluxation of the lens due to trauma, exfoliation syndrome, or hereditary disorders such as Marfan syndrome, etc. And very rarely there may be drug sensitivity, which causes the swelling of the lens. And mostly these drugs are sulfonamide group of sulfur group of containing drugs. Coming to the epidemiology, PACG with pupillary block occurs in 1/4 to 1/10 compared to POAG among Western countries. In India, the prevalence is equal, but in some studies, it shows that in southern part of India, there is a relative low rate of primary angle closure suspect with narrow angle, but PACG in these cases because of the plateau iris is very common. So PACG is rare compared to occludable angle. For every 10 occludable angle, what is occludable angle? Is nothing but you see through gonioscopy, and you find that patient has the angle structures are not visible, and then you do an indentation gonioscopy, you indent and angle opens. Okay, so that is called occludable angle. So for every 10 occludable angle, there is one case of primary angle closure glaucoma, and gonioscopy is poor predictor. Through only gonioscopy, you cannot know which patient is going to land up in angle closure glaucoma and when. Okay, the acute PACG is uncommon compared to chronic one. If we have one patient having acute PACG, that is acute presentation, which includes the sudden onset of pain, blurring of vision, headache, and redness of the eye. For every one patient, there is 3 other patients which are having chronic angle closure glaucoma, and majority of them are asymptomatic and they will not present to the clinician. Then there are some ethnic variability in angle closure glaucoma, and PACG is the major cause of world glaucoma blindness because these patients are not diagnosed properly, so they have more chances of presenting late to the ophthalmologist, and they once they present, they already have some damage done to their eyes. Okay, and it is more common in Chinese population because of the small axial length. So what are the demographic factors or risk factors? It is more common in Chinese ethnic origin. If you remember, primary open angle glaucoma, they are more common in African or American communities. This is more common in Chinese because they have short axial length. And it is more common in females, that is 1:2 male to female ratio is 1:4, and mostly it presents after 40 years, that is in 6th and 7th decade, and patients most commonly have hyperopia. So because of the hyperopia, there is something called as the crowding phenomenon. Crowding is nothing but the angle structures are structures which are present in the eye, they are placed very close to each other, that is iris is placed close to the lens, so that will lead to easy any change in the refractive status, that will lead to any change in the pupillary dilatation, that will lead to the early opposition of the iris and the lens. So the hyperopic patients or hypermetropia is risk factor, and it is more common in first degree relatives and common in the winter season. So what are the ocular risk factors? Just you have to remember, it is the patient who has short axial length, they have more chances of angle closure glaucoma. Okay, so shallow anterior chamber, it is uncommon if anterior chamber is more than 2.5 millimeter, and there is decreased AC volume, short axial length, thick lens, and increased posterior corneal curvature. These are all risk factors for causing angle closure glaucoma. Okay, so what are the precipitating factors? Just having a occludable angle is not enough. patients should have some precipitating factors such as dim illumination, emotional upset, or some type of medications evening hours of the time. Mostly these patients will present typical histories that they have gone to theater to watch a movie, and as soon as they enter theater, after 5 minutes they will start having shooting pain with headache and blurring of vision, and they will come to you. What happens when you go to movie theater? The illumination is less, so the pupil dilates. So once there is mid dilatation of the pupil, there is opposition between the iris and the lens that will lead to the symptoms of these angle closure glaucoma. So what are the medications? Mostly these are sympathomimetics and antipsychotic drugs such as antidepressants and antiparkinsonians. These are the drugs which cause the pupillary dilatation and lead to angle closure glaucoma. The other risk factors are the prone position, anxiety, and close work. I told you, because of the close work there is accommodation, and because of accommodation there is more opposition of the iris and the lens. There are some tests. These are not done routinely because these are of historical importance. They are not done routinely because they are not so much predictable and reproducible. But since it is given in the books, we have to read about them. Okay, so these are the nothing but provocative tests. What happens? We provoke these patients to these angles. We provoke these angles to go and occlude, and if the patient has symptoms of the angle closure glaucoma, then we get to raised intraocular pressure, then we say that patient has angle closure glaucoma. Okay, so the aim is to evaluate IOP in conjunction with occlusion of the angle so as to indicate eyes at risk for surgical intervention. Previously they used to do surgical iridotomy, so for that it was very much needed. So the first test in the provocative test is mydriatic test. What happens in this? We put a weak short acting topical mydriatic, that is tropicamide 0.5%, and we measure the IOP after half an hour. And if there is more than 8 millimeter of mercury change in that is rise in IOP, that means it is a positive, and we have to surgically intervene these patients. Other tests are dark room test, that is we have to keep the patient in dark room for 60 to 90 minutes to induce mydriasis. If there is increase in IOP, then more than 8 millimeter of mercury, that means it is positive. But what is the drawback? That most of the patients, they go to sleep, and that induces meiosis, and your test is false negative. Other tests are prone test and complex pharmacologic test. The disadvantages of this is they are not relevant and they are not recommended, because we have better methods of assessing these patients. And because in 10 to 30% of these patients, there is of angle closure patients, it is negative, and 5% there is false positive. So we have to so false positive tests are also not good, because we go ahead with doing peripheral iridotomy, which is not indicated in such patients. But recently ultrasonic guided measurement of anterior chamber depth has more sensitivity as compared to these tests. Okay, so first type of the angle closure glaucoma that is pupillary block glaucoma. It may be absolute or relative. Most commonly it is a relative block. Okay, so what happens, as I told you, what is the pathophysiology of pupillary block glaucoma? The lens iris opposition at the pupil with the resultant bowing forward of the peripheral iris. So this is the lens, this is the iris. There is opposition of the lens and the iris at the pupillary at the pupil because of the mid dilatation of the pupil, and this will lead to collection of the aqueous humor in the posterior chamber, and that will push the peripheral iris against the angle of the anterior chamber. So the trabecular meshwork and Schlem's canal, whatever the angles are there whatever the angle structures are there, they will be obstructed, and patient will have angle closure glaucoma. Okay, an anatomically predisposed eye that allows anterior displaced peripheral iris to occlude the trabecular iris. Same. Lens iris channel not needed for your level, and mostly it occurs in the mid dilatation of the pupil. So coming to the clinical spectrum of these patients, so in cases of primary angle closure suspect, it is a retrospective diagnosis. That is, there are no symptoms, and during an attack patient may have symptoms of the congestive angle, and angle is occludable in the gonioscopy. So how do you treat such angles? Without treatment, IOP may remain normal. Patient may go to acute or chronic closures. Okay, so prophylactic peripheral iridotomy is needed in the both eyes. If there is significant iridotrabecular contact persist after iridotomy, then you have to manage it with observation, laser iridoplasty, or pilocarpine. So previously pilocarpine was used as a first line of treatment, but nowadays pilocarpine is not used. Where it is used, I'll tell you. Okay, so if patient has PACS, then what is the treatment? The treatment is peripheral laser iridotomy in both the patient in the both the eyes. Okay. What is the primary angle closure? In this eye has occludable drainage angle and features of the trabecular obstruction. There will be recurrent attacks of the raised IOP, and IOP is usually normal between these two episodes. Okay, patient presents with the blurred vision and colored halos, headache, and mostly it occurs because of the physiological meiosis. And this should not be confused with the normal tension glaucoma or PACG. If you have any doubt, do gonioscopy. In case of normal tension glaucoma and PACG, the angles are absolutely open. So what is the treatment for PAC? The treatment is laser peripheral iridotomy or lens extraction with goniosynecholysis. Very important entity is acute attack of PAC, be pupillary block. The symptoms are red congested eye, severe pain, photophobia, colored halos, and blurring of vision, along with the other symptoms such as nausea and sweating. You have to differentiate the colored halos of the corneal edema along with the colored halos of the lens. Okay, how you differentiate is by the Fincham test. Then these are the symptoms. What are the signs of the angle closure glaucoma? Acute attack is the visual acuity is usually very poor, that is hand movement. Their IOP is very high, that is 40 to 70 millimeter of mercury, and there will be circumciliary congestion with the corneal edema, mid dilated vertically oval pupil, very important, and with shallow anterior chamber, and angles are closed. Okay, so examination of both the eyes are important. If you see in this picture, you have a mid dilated vertically oval pupil with the congested eye, and here if you see under slit-lamp, the anterior chamber is very shallow, and you can't see any structures once you do gonioscopy. So there is a criteria to define acute attack of angle closure, that is at least 2 of the symptoms with at least 3 of the signs. What are the symptoms? There will be ocular or periocular pain, there is diminution of vision, maybe hand movement or between 660 to hand movement. There will be history of intermittent blurring of vision, and IOP is more than 21 millimeter of mercury. What are the signs? There will be there will be ciliary flush or congestion, circumcorneal congestion. There will be corneal epithelial edema. There will be mid-dilated sluggish reactive pupil with shallow anterior chamber, and closed angles on gonioscopy, and there will be some changes in the perimetry. What are the signs which suggest previous episodes of angle closure? There will be peripheral anterior synechia. These are the anterior synechia which are present at the angle seen on gonioscopy. There will be posterior synechia to the lens. There will be posterior synechia through the lens, and there will be glaucoma flaken, and sectoral or generalized iris atrophy may be present, and you may have a pale optic disc, or there will be very large cupping in the optic disc. How do you manage a case of acute angle closure glaucoma? It is divided into 4 stages. First, you have to reduce IOP immediately. Then you have to do laser PI in both the eyes. And third is you have to protect the fellow eye and long-term treatment. Okay, these are the 4 stages of the treatment. First is medically, you have to give, last time I told you what are the hyperosmotic agents. Mostly you have to, most commonly used is the mannitol, 20% IV, 1 to 2 gram per kg you have to give in these patients, okay. And once the IUP has reduced, you have the other agents are the acetazolamide oral, most commonly we give oral drug. Along with that, you have to put patient on the topical beta blocker, timolol 1% twice in 30 minutes, or alpha 2 agonist, okay. Prostaglandin analogs, we may or may not give because there may be some amount of inflammation, so prostaglandin analogs are usually avoided. The important drugs are timolol and alpha 2 agonist. And if IUP, when IUP falls less than 50 millimeter of mercury, then only we have to put pilocarpine, okay. I told you what are the importance of pilocarpine is in constricting the pupil before doing a peripheral laser iridotomy, okay. So the pilocarpine is not the first choice of drug, because if IOP is more than 50 millimeter of mercury, the because of the iris ischemia, pilocarpine will not work, okay. So first you have to reduce the IOP by using different drugs, most commonly IV mannitol, followed by oral acetazolamide or Dimox, 250 milligram. 250 milligram tablet is available. You have to put topical beta blockers or alpha 2 agonist, and next you have to put is pilocarpine, either 2% or 4%. Along with this treatment, you have to put patient on topical steroid because there is some amount of inflammation or iritis. Patient should lie down in the supine position, and this pushes the lens iris diaphragm posteriorly. You have to give appropriate antiemetic and analgesic drugs, and if this is not decreasing the IOP, you have to indent the cornea through your gonio lens or through the glass rod available every 30 seconds interval, okay. So pilocarpine is today, it is used only in two conditions, that is before doing iridotomy and in case of plateau iris. Plateau iris I will be telling you in next class. There are some slit-lamp maneuvers. If the IOP is not reducing with your drugs, then what you do, you indent. This is the cornea, this is the angle structure. You indent cornea physically through using your Goldman's applanation tonometer, through using gonio lens, or through using a glass rod. You have to indent physically cornea. This what it does, it pushes the aqueous through the angle structures, and it pushes through the it causes the physical pressure, and that will open up the angle of the anterior chamber, okay. After IOP of the patient has been reduced, you can go ahead with peripheral laser iridotomy or peripheral iridoplasty. What is the What is the laser iridotomy? It is nothing but we make an opening in the iris. See, the problem lies here. If we because of this, there is pushing of the iris through the angle structure. So what we do, we may make a small opening in the iris, and this opening you can see here, it is done through the laser. And if we make an opening, then it has an alternate path. See, usually normally what happens, the aqueous humor from the posterior chamber to anterior chamber, it comes through the pupil. But if you make a small opening, there is an alternate route available for the aqueous humor to come into the anterior chamber and get drained. So that's how pupillary block will be avoided. What are the indications for peripheral laser iridotomy? Is acute angle closure, chronic angle closure. In the fellow eye also, if patient presents with one eye of the angle closure, that means the other eye is at risk, and you have to do a PI there also. And sometimes once you have done surgical PI and that is negative, that is incomplete, there also you can do laser PI, okay. PI is nothing but peripheral iridotomy. Procedure is not needed at your level. And if your this laser peripheral iridotomy fails, you may go ahead with the surgical PI, okay. But this is not so much indication, because it is an invasive procedure, okay. You have to go inside the eye. That's why the first line of management is laser. Okay, what are the indications if the laser fails to produce a patent iridotomy? Okay, so if you have to see for trans elimination test, if there is no elimination, that means the laser has, especially in dark colored iris, this laser fails. Okay, so there you have to surgically intervene the patient. And if laser iridotomies are repeatedly closing because of the increased inflammation in the eye, that is clogging the opening of the iridotomies there. If the patient has very shallow anterior chamber, what happens if patient has very shallow anterior chamber? Your laser there is chance of hitting the laser to the cornea, because cornea and iris are very close to each other. So to avoid corneal burn, we go ahead with the surgical iridotomy. And in cases of the corneal opacities which interfere with the laser treatment, and if laser is not available, or if the patient is present, if you are posted in some rural setup where laser machine is not available, you can go ahead with the surgical iridotomy. Okay, gonioplasty I'll be telling you in next class. What is the chronic angle closure glaucoma? It is the most difficult to diagnose because patient will have no symptom, patient will have no signs, but however there are some little signs which are present, okay, such as glaucoma flaken. What happens because of the increased intraocular pressure? There is some ischemia of the lens, so this is nothing but the ischemic lens. Because of the some small cataractous changes will be present, this is called glaucoma flaken. There will be some little iris atrophy which is present, and there may be some pigments over the anterior chamber, and mostly these patients have visual field and optic disc changes. So these changes are usually present, but clinically these patients are normal. Mostly it happens because of the repeated subacute angle closure and creeping angle, that is slowly the angle is occluding. How do you manage these patients? We have to do laser PI, okay, whenever indicated. And if IOP is not getting maintained at optimal level, you may give these patients topical drugs such as beta blockers or alpha 2 agonist. And surgery is indicated. Mostly surgeries which we do is iridotomy, lens extraction, and trabeculectomy. Okay, last stage of angle closure glaucoma is absolute glaucoma, that is patient has painful blind eye. In this patient there is no vision, but because the angles are obstructed, the fluid or the aqueous humor is collecting in the anterior chamber, and which causes a lot of pain. Okay, so there patients will have persistently elevated IOP. There will be perilimbal reddish blue zone. There will be some bullous keratopathy. There will be corneal vascularization of and atrophic iris and pupil. Oh, absolutely, there is patient has what we call is optic atrophy. The optic nerve is not functioning at all, but still patient has pain. What you do for these patients? We may give retrobulbar alcohol injection, which is 80% 1 ml injection given to block the ciliary ganglion. What we do, if we block the ciliary ganglion, the pain reduces and the aqueous humor formation decreases. Okay, if this does not occur, what we have to do is the cryotherapy or cyclocryotherapy or cyclodiathermy, or more commonly nowadays used is the cyclophotocoagulation. What we do is we coagulate the ciliary body or ciliary structures which are present. We give a laser burn to those ciliary processes, and so the formation of the aqueous humor reduces. If all these maneuvers fail, what we do is enucleation of the eyeball. That is the last sort, which is that is the last treatment which is available for painful blind eye. Plateau iris I'll be talking in next class. Thank you so much.